So the community health and wellbeing workers, based on the Brazilian family health strategy, a frugal and effective approach to health inequities. So let me tell you a bit about the Brazilian family health strategy. Dr. Matt Harris, who is a fellow public health consultant at Imperial, who worked as a GP in Brazil, and these 4 people are his community health workers in Recife in Brazil. He worked there for a number of years and thought this is such an ingenious role. I wonder why we don't have that in the UK. So here you can see the honeycomb in the middle. The big dot is a GP practice, and then the pies around it are the community health workers. There's about 4 to 6 per practice, and each of those community health workers reaches out to about 150 households in a defined geography, and they see each one of those households once a month. And as long as you live in that area, you have a community health workers, and when you move out of that area, you lose that community health worker. It started off in the early 90s as a response to a cholera epidemic when, as you know, Brazil is quite a vast country, and they needed to get diarrhea sachets and water and everything into the communities quickly, and they employed local people from those communities to do that. And then they realized that they had stumbled upon really amazing infrastructure, community infrastructure, and they built on this model. And they now have actually over 270 community health workers covering about 75% of the population. And over time, they have seen a 10% drop in hospital admissions, 36% drop in cardiovascular disease mortality, a 30% drop in stroke mortality, reduced horizontal inequity, and the breastfeeding rates there were at about 0.5%, same as the UK at the moment at 1 year. And they are now at nearly 60% in Brazil. Immunization uptake increased and much more. So what can we learn from the Brazilian system? We have widening and entrenched health inequity and unequal access and experience of health and social care, whereas in Brazil they have the local universal proactive outreach to up to 150 households each, which deliver early help and prevention. Local lay people are trained and paid, and they are rapidly deployed in the community and easy to scale. And this contrasts with our workforce crisis, where we've got long training times, recruitment and retention crisis, and we've got these kind of 2 pools of people. So we've got on the one hand the ever dwindling pool of highly trained professionals that we sort of poach from primary care to secondary care and back. And then we've got people who are not able to get gainful employment because they don't have the right skills and the right networks. So you might be familiar with Hilary Cottam and her book Radical Help, where she points out that about 90% of the jobs nowadays are obtained through networks and contacts and recommendations. So if you're outside those networks, you don't get a look in. And the community health workers present a bridge from volunteering in the community into gainful employment. They're comprehensive at the household level, taking into account a person's social context. And we know that social factors determine about 80% of our health, and only 20% are contributed by timely access to good healthcare. So we don't do very well at prevention at the moment in the UK, and we focus all of our resources at the sharp end, where things are really difficult, if not impossible, to fix, and very, very expensive. And in Brazil, you've got the integrated primary care team, and here we've got fragmented and expensive care and unacceptable variations in care. So a shout out to Westminster Council, particularly Public Health, for seed funding this pilot in 2021 in Churchill Gardens. And we set out with these 4 community health workers who were all community or maternity champions in the locality at the time, Asma, Maureen, Nahima and Comfort, and they between them looked after about 500 households and still do. We set the bar really low for the pilot. We said we want to set out to prove, is it acceptable to residents, because there was a concern that this might be perceived as intrusive. And is it feasible in this really busy service landscape that we have? There are community health and wellbeing workers all over the world in many countries, including the US, Nigeria, India, many more. We think that the Brazilian model holds the most promise because of the CHU-I principle. The CHU-I principle stands for C for comprehensive, holistic at the household level, H for hyperlocal, so people from that community for that community, universal, so proportionately universal, everybody is included, and this is how you discover the unknown unknowns, and integrated in the general practice, in the voluntary sector and the local authority. And this is how they work in a nutshell. So they primarily look after their relationships with their own residents, with 120 households. And then their secondary remit is to build relationships with all the professionals around them. So they know by name and have the number in their phones of the community matrons, the district nurses, the family navigators, the GPs, the community champions, you name it. And this kind of gives an illustration of what life is like without a community health worker at the moment in our present system. So on the left-hand side, you can see a family, mom and dad, 36 and 35 years old. Mom is pregnant. They live with 4 children, 12-year-old, 15-year-old, a 1-year-old, and a 17-year-old, and the 88-year-old grandmother. So grandmother falls over in the street, gets admitted to hospital, and social care gets plugged in, and she has a package of care reactively. The 12-year-old gets picked up by safeguarding because mom presents to the GP feeling suicidal. She didn't want to have another pregnancy. She gets referred to the antenatal services late. That presents separately to the GP about housing need. The 17-year-old gets picked up by the police, the school gets plugged in, and we don't even know about the unknown needs of the 15-year-old and the 1-year-old. 15-year-old probably thinking about contraception because she just started seeing someone, but doesn't know who to ask about it. And there you go, a fragmented service. Referral dependent, reliant on needs recognition, late intervention by definition, and a lack of context or relationship. And then imagine the same family with a community health and wellbeing worker who builds a trusted and regular relationship with that household. The 15-year-old, and this is based on actual case studies, the 15-year-old feels empowered to talk to the community health worker about contraception. The community health worker proactively discovers that the mom is getting quite low in mood. She sees the housing issue up front and intervenes early. She can also see that the grandmother is quite wobbly and probably could do with some adjustments around the house. She plugs in the care coordinator. And the consequences of this proactive approach is that you have the needs recognized collectively, and that you potentially prevent an unwanted pregnancy and a fall, amongst many other things. So here's Churchill Gardens, and the colours represent a community health worker. We had money for about half of those houses on the estate, and the other houses acted as controls for the pilot, for the evaluation. And this is a key feature of the community health workers. They don't need to have particular skills. They're recruited on character and not job characteristics, because we want to have the right people in the community who are trustworthy, integral, honest, team players, culturally competent, empathic, non-judgmental, eager and willing to learn, passionate about their community, and good listeners and communicators. And they then get rigorously trained on the job. So they get training on patient confidentiality, information governance, making every contact count, health coaching, just listening, bereavement support, lots of different training. So this is an example of them receiving training from the Human Milk Foundation and the Association of Breastfeeding Mothers. Mental health training from CNWL with Amanda Bueno on dialogical approaches to mental health. Dementia training, so how to recognize cognitive decline and how to support people with dementia over the life course and their carers. We have themed coffee mornings that they organise, so their residents get together once a month. This was September Dementia Coffee Morning, where we had Dr. Nair presenting from Imperial about dementia and what it is. And then I was there to talk about the local offer from the GPs and others for dementia. You might have come across this, and this talk is about health inequality. So this is NHS England's answer to health inequality. So they've done the number crunching and found the core 20+5. So the health inequalities are driven mainly by people, the 20% most deprived population, and by 5 conditions. So the late recognition of pregnancies and adverse outcomes, severe mental illness, chronic respiratory disease, late cancer diagnosis and adverse outcomes, and so what's the other one? Cancer, respiratory, and uncontrolled and unrecognized high blood pressure. And the plus is those who are not in the data, so travelling populations, homeless people, and many more. The core 20+5 is a really medical lens on a social problem. So if you think about what's behind all of those conditions, so severe mental health, often generational trauma, lack of education, lack of power, poor antenatal outcomes, there's often domestic violence, racism, poor maternal mental health, deprivation, lack of access, respiratory disease, smoking, occupational hazards, poor housing, air pollution, lack of access, etc. And I call the community health workers the core 20+5 on steroids, because they work across these 5 domains and many more. And I'm not going to read out the entire list, but there are examples here, so of them bridging midwives and health visitors, encouraging vaccinations, smoking cessation, talking about screening uptake. They take blood pressure in the community. They talk to people about their home measurements, help with medicines compliance, and so on. We did some process mapping of what they actually do rather than work as imagined, and we mapped that out quite carefully with them and with stakeholders. And you can't read these maps, but just to give you an idea of the complexity of what they do across these domains and how they connect them. And we did some interviews with stakeholders and the community health workers, and I'll just share these ones with you because we haven't got much time. But so this is a GP talking about their interaction with the community health workers. They say the concern when we started this project was that they would be bringing a whole lot of work back to us, the GP practice, but they have connected the community to all the other roles which are out there. In many ways, they've diverted work from me into a system which will help the patients. A quote from the community health worker that shows that the conditions are interconnected. So I help her with the ventilation at home because we need to support her. I talk to the GP, to housing, 2 problems together, cancer and respiratory system. It's not a problem. It's not easy at all. She has lung cancer and is living in the sofa in the hall. If you don't go inside the community, you can't discover how people suffer. So here's the intersection between chronic respiratory disease, early cancer diagnosis, housing issues, and mental health. And then a resident-focused approach. So there's somebody saying from the local authority saying when we're passing people on to mental health services, we have to do it on the understanding that they are under-resourced and overstretched, and they often don't approach people in the way that they need to be approached because of the limitations of the service and the situation that is multifaceted. So in that research with the process mapping, we used the Collin and Bilge framework for inequalities. And there are 6 domains, so complexity, power relations, connectedness, social context, and social inequality. And our research mapped on how the community health workers are able to address the inequalities. So for complexity, because they meet the household and interact with that household and know the situation in the home, the neighbours, the community, they can act much more intelligently. Professor Fleur de Meer, who's a professor of primary care in Holland, she calls this community precision community medicine. And this is because they are able to really target personalize their approach to this family. So while us in a service landscape, we think about a patient coming to us, they might need a social prescriber or they might need a diabetes check. So we think about services and referral pathways, but the community health workers think about who's the right person who's around that is appropriate for that family to help them. So that could be the grandmother, that could be another community health worker who happens to speak Chinese. It could be the social prescribers who they know by name and they know that they can help. Power relations, so they shift that medical-centered approach where all the power sits with the medical professionals and none with the patients to redress those power relations because of their advocacy and allyship and integrations with the agencies. So one of the community health and wellbeing workers who used to be a maternity champion, she said, it's like being a community champion, but with a backbone and teeth. The backbone being the community, the primary care practice, the general practice, and the teeth, the fact that they have, through their professional status, relationships with housing, adult social care, the communities, service providers, connectedness. So they stimulate community strategies, they connect the household, neighborhood and agencies by leveraging their trust and their relationships. So they hold these monthly coffee mornings that I mentioned. They have a really good overview of what services exist in the community, and they empower social participation in their residents. So there was one lady who lived in Churchill Gardens for 40 years, didn't know anyone, never really went out, and she's now meeting the community health worker in the coffee shop and is participating in the coffee mornings and is really now making friends in the community. Social context, so they incorporate that by visiting people in their home and work to include a patient's network. And I want to share an example of a patient who presented at the practice every week with demands for painkillers, for back pain. They had been to the surgeons, the physios, they had injections, everything had been done for them. And they are one of those hard-saying patients that we don't like to see in general practice because there's not much we can do for them. And the community health worker visited them at home and spotted that they're sitting on a very rickety garden chair. And they brought that up and said it can't be good for your back. They sourced him a garden chair, another chair, and the back pain got better. But it made me think, do I ever ask people what they sit on or what they sleep on, whether they sleep in a sofa in the hallway? I have to confess that I don't. But even if I did, would they tell me? Because would they be embarrassed? Or if I recommended that they get new furniture, they don't have any money to get it, would they do it? So there's something really important about understanding how a person lives and what's important to them. Social inequality. So the program is offered as a priority to the bottom 20% most deprived, and social justice because they promote universal opportunities and they're proportionately universal. So they will direct their attention where it's needed and where they see it rather than who shouts the loudest. Headline findings from our evaluation at 1 year of the pilot. We helped 4 people into employment. We reached about 40% of the households by year 1 and 60% by 1.5 years. We had increasing and continuous engagement and, importantly, no disengagement once somebody had engaged. 47% more likely to have immunizations, 82% more likely to have cancer screening and NHS health checks if that family had a community health worker, and the GP visits dropped by 7%. And one of the GP partners who'd worked there for 30 years as a partner said intuitively she felt that the noise from Churchill Gardens had died down about these non-medical requests. And here you can see what hard work it is. They spend a huge amount of their time unsuccessfully door knocking, and you might feel that that's a waste of money, but really this is the effort that's needed to get the community engaged. And just this week, so I meet with the community health workers once a week to discuss residents' cases. One of the community health worker knocked on the door with a new community health worker because we've now expanded to 33 in Westminster. And she said, you probably don't want to see me today, because for 2 years she had always said no. And then she said, well, I'm cleaning my house, but you can come in. And then after a 20-minute conversation, wanted to volunteer in the community and give them all a big hug. And they've made an appointment for next month. So that's two years. Another family that said, we can talk to you about anything, but we don't want to talk about our health. That's between us and the GP. And for 2 years, they've been drinking tea and talking about everything else. And this person broke her hip, and the first person to call was the community health worker. So they act as a bit of a catalyst in the community. They're ready for when crisis hits. They're the first point of contact and the first port of call. So what are the benefits of holistic proactive outreach by geography in that way? We've seen many, so identification of child carers, combating loneliness, suicide prevention, carer support, crisis mitigation, bereavement support, many more. And what are our system insights from the 3 years of community health working? I would say these three. Targeted interventions absolutely missed the mark. And I will tell you why. Starting with data is looking in the wrong place. And then increasing services in the main won't work, because there is a washing away of place-based investment and a runoff. And I'll explain this a bit more. So first of all, I want to talk about the unknown unknowns. So you might recognize this. This is the story of Abraham Wald, who was a statistician in World War II with the American Army. And he was consulted on where to put reinforcing plating on the planes returning, going into battle. And they looked at the planes that have come back from battle, and they looked at the bullet holes, and they wanted to put the plating where the bullet holes are. And Abraham Wald said, no, put it where there's no bullet holes, because he'd recognized that this was survivor bias. The planes that had been shot down were not available for inspection, and probably the areas that were not hit are those that are the most vulnerable. And you can imagine those bullet holes are probably the data points that we hold for people in the system. So when we know that somebody's got leg amputations, chronic disease stage 4, diabetes, a heart attack, those are the people who engage with us in the services. What we've discovered with the community health workers is that there are a lot of people who are registered with a GP, but they don't actually go and see the GP at all. So the community health worker finds that they did have a heart attack, and they get their medication from abroad, and they take it when they have a headache. And these are the people we need to reach, because the first time that they will come across the system will be when they die. And this might explain some of the 18-year life expectancy gap that we see in the borough. So why are underserved populations so hard to reach? First of all, lack of access and poor experience. So when we send out our text messages from the practice or from the local authority, when we distribute flyers, we expect that they land somewhere, but we've learned that a lot of people don't have access. They don't have a phone. They don't have the internet. They share it. They can't read or write, and they are excluded. An unawareness of need. So we discovered child carers where 12-year-olds were booking hospital appointments, being the translator at a GP appointment, sorting out social care. And it took the community health worker to point that out and say, you don't need to do that. We've got people, and brought in the care coordinator and focused on the child. Neither the children nor the adults thought that there was anything wrong with that. And they certainly wouldn't have reached out. People don't prioritize health, so they worry more about their housing issue, their family. And the majority of conversations in the first year with the community health workers were not about medical things. They were about social things. And if you don't address them, people are not interested in prevention. And there's a lack of understanding from the provider side of what the issues are. We have blunt tools, we generalize, we use leaflets and messaging that isn't personalized. And then there's this issue of forced transience. So we discovered that people often move into the area. So there was one family that was quite traumatized that moved into the area. The community health worker helped them connect into the neighborhood and build this really fragile network. And Lucy Easthope calls it the lifescape. So your home is not just your house, it's also the people that you know, your neighbors, your the gym that you go to, the friends that you have, the moms that you know from the school, the moms and dads, the football you play locally. And when you move, you get uprooted, you destroy that lifescape. So a lot of the time when we invest in place-based solutions, that gets washed away when a family gets moved because their housing falls through and they start from scratch, and that money is wasted. So lessons that we learned along the way: utilizing volunteers is important, but it's not enough. You can't have that kind of responsibility and asking that of a volunteer. And it can be counterproductive, because when you have people from that community for that community, people often worry about gossiping. So you really need to have that professional standing, training, support, integration and supervision to make that work. Transients, like I just described, is not a given. So we can have assertive action for residents, and that is needed to keep the money locally and keep it in place and invest in people, and for that to return to the locality. To address health and well-being, social factors have to be addressed first. Proportionate universality is important to reach those who need help the most, and it may feel like a waste of money, but it really isn't, because you catch people when they're falling rather than picking them off the floor when they've been there for a long time, when things are really expensive. And understanding of the service landscape is needed to prevent this runoff. And what I mean by that is Westminster spends about 128% of resources in deprived areas compared to areas that are better off. But where does that money go? It doesn't make a dent. It doesn't touch the sides. And why is that? And some insight that emerged from the community health workers is that it's a bit like sort of dry, hardened earth, that you get this kind of torrential rain and it runs off. Because we don't know what each other do, so the local authority doesn't know what services the NHS puts in place and vice versa, you end up with this plethora of different services that get sort of thrown at the community, and the community does what you and I would do. They either game the system and play people off against each other because nobody holds the cup, or it just shut down completely and turn their phones off, are not available, don't answer their emails, and that's what makes them hard to reach. So to prevent that, it needs a kind of trickling rain, and this is what I think the community health workers are. So they're kind of like rain softening the earth, but it takes a monthly visit and another one and gentle conversations that are personalized. And community interventions take time. So the World Health Organization puts it at about 5 years. And then now think about our commissioning structures usually covering 6 months to 12 months. And that's not enough time. It needs time and resource to stick. And integration is key. So we have now 25 full-time community health and wellbeing workers in Westminster, and these are the areas. The coloured areas that you can see are villages of 120 households in the most deprived areas in Westminster. We mapped out 76 of such villages, and we don't have 76 community health workers at the moment. So we randomly allocated them to those areas of need. That seemed to be the fairest way, but it also allows the George Institute and the Imperial College London to run a parallel arm step wedge trial to see if we can replicate those amazing findings from the small pilot in Churchill Gardens. It needs the ecosystem. So we have an integrated neighbourhood system in Westminster called the Octopus, which is the idea of Dr. Saul Kaufman, who's a clinical director in Westminster. He was inspired by the way that the community health workers work intelligently to bring in who has the right skills, not who has the right job description. And why Octopus? Octopus because we have 8 connector roles in the community health and wellbeing workers, the wellbeing coaches, the social prescribers, the family navigators, and so on. 3 hearts. I didn't know that the Octopus has 3 hearts, but the voluntary sector, the NHS and local authority, and 1 brain, which is academia. And importantly, the cephalopod doesn't have a centralized nervous system, so all of the tentacles work independently for the benefit of the whole. So that was also the idea of the frontline roles being empowered, having agency and control. So the community health workers, I'm pleased to say, are spreading nationally, and this is thanks to the National Association of Primary Care, who are championing this model for a national rollout. So we have all of these places in London alone. We've got Westminster, Harrow, Hounslow, Hammersmith and Fulham, Wandsworth, Merton, Croydon, Kingston, Richmond, Sutton, and then all these other places. But I would say don't be fooled by that. It may look established, but it's really at the point where it's a fragile plant that had been given enough water, air, soil and protection to grow, but it's kind of a very tender plant and it needs really sustainable resource to grow. And there are risks associated with this. So the risks are short-term and non-recurrent funding. So in RBKC, for example, the public health seed funding stopped and the NHS didn't take it over and it folded. And there's quite a lot of damage you can do by investing in relationships in such a traumatized community, and then if you pull the plug, you lose the trust and engagement from that community. Other risks are that you don't stay true to the model, the CHU model that I talked about, that the model is rushed and you set unachievable KPIs and then pull the funding. In Cornwall, the ICB have invested 1.7 million of all of their health and equality funding into this model. They have 35 community health workers, and this kind of sustainable funding is needed to make it stick. And I want to leave you with this depressing slide. The Health Foundation report came out last week, which shows that they project 700,000 more workers will be living with major illnesses by 2040. Nearly 25% of more working age adults will have diagnosed major illnesses by that's 3.7 million. 80% of this increase will be in more deprived areas. And people in the most deprived areas will develop major illness 10 years earlier and 3 times more likely to die by the age of 70. The conditions that are projected to grow the fastest are chronic pain, type 2 diabetes, and anxiety and depression. And it's too depressing to read on, so I'll leave you with it, and hopefully you can find it on the internet and read it yourself. But more than ever, the community health workers are needed. So I'm going to stop here and take questions. If there are any.
Thank you so much, Connie. Paul, did you want to come in with your question?
I do. I found that incredibly interesting. Incredible, actually. What an intervention like that can do. I don't know. I'm thinking. I've got one question definitely on top. So you said you've got 4 full-time employees who are health care workers. I saw the picture at the front. There seem to have lots more women. I got a couple of questions there. Was it all women who volunteered? That was one question. How come only 4? I was intrigued why it only ended up as 4, because it looked like you took on a lot more. And my actually longer term question is, I can see the issues of funding. Is there any way it can be kind of seeded so that, I don't know, if you even looked into this, you help a community or whatever, and then you get some of the people who were helped in that who then want to be those community workers to kind of get it going further. I don't know. And so my final question is, what's the salary of one of these people? I'm just curious how expensive it is. Yeah. So sorry, that's loads of questions about labour markets.
No, absolutely. No, thank you, Paul. So I'll go through them if I remember. So women, yes. Weirdly, you hit the nail on the head. It's often women who volunteer in the community, and they know the community really well, and it appeals to them in terms of kind of caring. It's interesting that in Brazil, 80% of the community health workers are women, 20% men. They have a similar role in the community that goes out doing pest control, and that tends to be 80% men. So I don't know if there's something. Is it kind of like nurture and nature? I don't know, but but yeah, we actually now have one male community health worker in North Westminster, Hamza, who hopefully will lead the way for other men to sign up as that model grows. Why only 4? So it was basically funding constraint from public health. We had about 100,000 to play with, and that paid for 4 community health workers for a year, plus uniforms that they wear, and learn working devices and all the other things, laptops, etc. So so you can guess from the salary, it's sort of like a band 2 type role. So it's quite a low paid role relatively, but hugely rewarding. So our community health workers, the 4, I've seen a huge difference in them, and it really gives me hope that about sort of empowerment, how quickly you see somebody really blossom. And so Asma had been volunteering in this country for 15 years, and I always used to be a little bit judgy about sort of people who live in the UK for a long time and don't speak English that well, but sort of she had very low confidence because she wouldn't be able to use her English skills because she was very kind of contained within her own community, speaking Arabic all day. And the change I've seen with her sort of interacting with different people and using her language skills and building on her knowledge is just phenomenal. So it's really made me rethink what the situation is, that really understanding that. You also asked about the seed funding. So interestingly, the anecdote that I told you for one of the community health workers finally engaging with somebody after 2 years who'd always refused them, she actually said, I'm really interested in volunteering in the community. They absolutely are a recruiting a process of recruiting people to volunteering, because they have been community champions themselves, and they then encourage people to volunteer. And you can see that at the end of it, there's going to be a paid job, a paid role. And the job satisfaction is also great in the community health workers because they use their own community much better. So our community health workers now know a lot more that goes on the patch, and then use that for their own kids. And so it really is. It strikes me sometimes that the community is a bit like gardening. You put in a little bit of effort and a little bit of water, and everything starts thriving. So our community health workers, they clocked up 50 hours volunteering as maternity champions on their weekend, so they give and give and give for very little money. It stands to reason that this is a really good way of investing money. So much more to say. I think, did I answer your questions, Paul?
Yeah, you did. That's really helpful, actually. Thank you so much. I do have another one, but I'll let anyone else go first.
I don't think anybody has their hand up at the moment.
Yeah, sorry.
Oh,
I
fantastic.
didn't put my hand up, but I'll pop on camera for the question. Thank you so much. That was, a brilliant talk. So I'm from the Institute of Healthy Urban Living at the University of Westminster. And it's just, it's just great to hear about everything going on in the local area. One thing that struck me is that this role is such it requires such a high level of emotional investment from the workers themselves, and those rewards that they get are incredible, but they've put so much into it. We're talking about years, not kind of hours or days or weeks. So is there any kind of, I guess, how do they get supported themselves? Because I could see that would be really taxing.
Thank you so much for that question, because that is a really, really crucial point. And I think it's also a reason why a lot of our, this explains some of the retention crisis, because we have so many roles that get kind of parachuted in. You employ a social prescriber, you think they tick all the boxes, they've done their training, you parachute them in and you leave them to it, and they're kind of, well, I'm being left with these heart sink patients, like one after the other. And and so the community health workers are different because they are a team, so the support that they give to each other is phenomenal. They discuss anything that's tricky or thorny with each other first. They get clinical supervision from me once a week, so I meet with them for an hour and a half to talk about tricky residents. They get support from all of the roles that they're actively introduced to and encouraged to work with. So it's the octopus kind of wrapping around them. And they also, we recognize this need because what we underestimated was the vicarious trauma that they carry from being exposed to such difficult living conditions. So we totally underestimated how long it takes to kind of get traction with the community because of the trauma and the difficult situations that go under the radar of all of our institutions. So we introduced just listening. It's something that I talked about in training with Amanda Buena, and this is a way of providing. It's basically, the idea is that you don't try and fix people. So the idea is that everybody has their own innate inner wisdom to know how to help themselves, and by giving them time and space and listening to them to work through that story at their own pace, people can access that knowledge, but you don't clobber them with advice that's not for them, or sort of they have regular intervision, so they listen to each other. So if they listen to a resident and they're really burdened by that, they then in turn get listened to by one of the team, by myself, by Amanda, or somebody else. So that's really, really important that they look after their own well-being. Yeah.
Thank you. It's really interesting.
Thank you. I think it's
we've got
Alicia and then
Alicia.
Paul again. Yeah.
Hey Connie, really quick question. I've been to quite a few activities and away days in regards to the NHS's approach to tackling health inequality with the Core 20+5. I just wanted to know how widely this approach has been adapted or implemented within the NHS, because I know that they're also, the main focus was around adults, but they're also looking to adapt it for children. So is this a widespread call for action, or is it still kind of in its infancy?
So you're talking about the Core 20+5 programme, Alicia?
Yeah.
Yeah. So interestingly, Professor Bola Owolabi, who is the director of the Core 20+5 programme and health inequalities, came to visit the community health workers a few weeks ago, and she came up with this program because she realized that you need people from the community for the community, but it was basically like I said, it's a very medical lens on a social problem, and that's kind of, you can only see what you can see from inside your institution. So Bola herself admits that this is not, the community health workers are a really good way of doing that by paying people, creating community infrastructure in a way that the volunteers can't really achieve. And interestingly, Thomas Harevaler, who leads on the community health workers in Southwest London, he also won Core 20+5 monies for the voluntary community connectors, and he was able to contrast how much further the community health wellbeing workers can reach compared to the Core 20+5 connectors that inevitably focus on just one condition or a particular patient group, and they're limited by the volunteering. I'm not sure that it's widespread. They had 3 waves, and I think most ICBs took part in the Core 20+5, but I think the funding is now running out, as always is the case. So we won Core 20+5 funding for 1 year, 2 years actually, with the community health workers after applying unsuccessfully twice. But it's just one of those things that I'm not sure. They're kind of expecting that now to be taken over by the community and other people. Just a whole problem in itself that I could talk about for hours.
Thanks, Connie.
Okay. Paul?
Sorry, I've got another 4 questions, so if you don't mind. So one of these, and you might not know, some of these questions you might not know from the trial, but you might just have a feeling or know from other elsewhere. Is it more effective having people from the same social group being the community outreacher? So I don't know, by age, social class, ethnicities. Did you see any of that? That was easier for certain, connected second question on that. Is there any groups you think just find it more difficult to engage, whatever, I don't know, by ethnicity, I don't know, they're more withdrawn, I don't know, first generation immigrants versus second generation, just, you know, anything you've got to add on that? I mean, it strikes me of all of this, it's coming back to the Brazil thing, that this would be a model. I know it's going to the deprived people, this potentially is a good model for everybody. You know what I mean? We talk about inequality.
Thank you, Paul.
But effectively, what you could argue, there's bad health comes across everyone. It's just that we only see the inequality, we don't see the bad thing.
Yes.
How
I mean, to be honest,
good,
Paul, I could use the community health and wellbeing worker anyway.
Yeah. No, that was kind of my point. Yeah, so you've kind of answered my question. So that was it really, which was going to be, do you think this is applicable basically all the way up the chain? You know, you see obviously things like bulimia and certain things that come up in the families or what have you, you know, from very wealthy families. And, you know, I mean, whether they be able to get in, there might be access problems there. Exactly. And so that's almost my fourth question, mental health problems. I was going to say mental health services are so bad these days. Was there any, you're getting access, was there any problem with this whole community work? I can put you in touch with X, Y and Z, but on mental health, it was so bad, you know what I mean? Is that just such a fundamentally bad problem for the whole system that's creating real problems here? And there you go, that's it.
Okay, so I'll go backwards from your questions. So first of all, mental health, absolutely. So this is I mean, I'm afraid to say the mental health services are probably not fit for service, if not to say almost harmful, in the way that people get passed around the system. So if somebody is in crisis and they go and speak to the crisis doctor who assesses them for an hour, and they kind of, you know, open themselves up and tell them about all of their lives and their trauma, and then they have to do it all over again for the next person who assesses them for a pathway that they go on, and then they have to open up again and again and again, and it's just terrible. So it's really fragmented, and that's why we're really promoting this dialogical approach where actually you use assets in the community. The open dialogue approach comes from Finland, where they said, actually, you know, what we do is when somebody is in crisis, they're suicidal or psychotic, we kind of sit on them, we sedate them to the hilt, and then we wait till they're kind of halfway normal, and then we try and therapize them. And what they say in Finland is that actually, in this moment of crisis, in this moment of psychosis or suicidality, there is a really huge potential to address the problem if you sit with that person, you listen to that person, so nothing about you without you. You integrate the entire self-declared social network, so you bring in the neighbor, you bring in the family to help this person in crisis, and that's shown huge benefits. So not only are you using the assets in the community, but you're also, they've halved hospital admission with mental health conditions, they've halved antipsychotic use, they brought people back into employment and university quicker. So this is what we're trying to achieve with the community health workers, that they feel empowered to deliver mental health interventions and provide a bit of psychological continuity. We also find that with sort of autistic residents, they find the service landscape really, really difficult to navigate. I mean, it's difficult for me. I don't know how anybody else copes. I mean, if I'm inside the system and I kind of don't really understand it. So there it's really important to have this personalized approach where you have somebody who can hold the hand and explain and come with. And so our community health workers have increase the cervical screening rates because they actually go with women to the FGM cervical screening clinic or to the clinic, or explain who does the cervical screening. So this is where I see the potential. In terms of your question about does everybody need community health workers, I agree with you. I think obviously times of crisis like we have, where the budgets are creaking and we can't even pay for the sharp end anymore, it's probably hard to argue. But we did a modelling paper, the HEYO paper that came out in 2018, modelling the community health workers. It would cost about 2 billion if every household in the country in England had a community health workers per annum, which is tiny, peanuts in NHS terms. So if you only focus on the bottom 20% most deprived population in England, it would cost 300 million a year, which is basically the budget for unused medicines. I mean, that's the cost of unused medicines in the UK alone. So there is huge waste in the system, and this is a really frugal intervention. Your other question, so the social connectedness, this is really interesting. So I think it really works that it's people from that community who understand it, who live it, who live there, who they do have more face validity than anybody else. But does it need to be the same ethnicity? I don't agree. And I think so. When we started the Churchill Gardens pilot, the senior GP partner said, well, there's the Arabic community and there's the Bangladeshi community, and you absolutely have to have a Bangladeshi community health worker and an Arabic community health worker, because otherwise they will not engage. We haven't found that at all. So we found the opposite almost. But we're just sending in anybody because we don't have a choice anyway. And what the unexpected benefit of this is that it increases social cohesion, because suddenly our community health workers, so Asma is from Sudan, Comfort is from Nigeria, and so they're different ethnicities that they actually mix with people that they would never have envisaged mixing with and being friends with. So but it is important that they're professional, so they wouldn't get that kind of access to the family of being from the community if they didn't reassure them that everything is absolutely confidential and they won't divulge anything. And some people more difficult to engage, probably young people from this country who think they don't need it. So, which is fine. I mean, you can't force people to have it. And often what you find is that the community health workers will offer their services. People go, no, my neighbour needs you more. I can't really think of anything. And then they'll go, actually, I do have something. And this is how it starts. And then they get their foot in the door and it goes from there, but it takes time. I think I've addressed all of your questions. Thank